You know, the skin can tell a story, especially when the immune system is under attack. Today, we're going to tackle a classic clinical question that really hinges on reading those stories, the signs of HIV that pop up right on the surface. Let's see if we can spot the lie among the truths. Okay, so here's our challenge for today. We've got 4 statements about HIV and AIDS. Now, 3 of them, they're spot-on clinical facts, but one of them is a clever imposter. Your job is to figure out which one just doesn't quite fit the picture. So yeah, our whole mission here is to find that one false statement, because figuring this out isn't just for passing a test. It really sharpens our clinical eye for how HIV actually shows up in a real patient. Here's our game plan. We'll start with the puzzle itself, then we'll unmask the exception, confirm why all the other facts are true, zoom out to see the bigger picture, and then we'll wrap it all up with the key points you're definitely going to want to remember. So what's the central idea here? Well, think about it like this. The skin and the mouth are like these big, bright windows right into the immune system. With HIV, what we see in these places aren't just some minor issues. They're vital clues about how the disease is progressing. All right, let's get straight to it then. Have you spotted the exception yet? Which one is it? And there it is. The exception, the incorrect statement, is A, this idea that oral hairy leukoplakia is intensely painful. Nope, that's just flat out wrong. And understanding why it's wrong is absolutely crucial for a correct diagnosis.
So what exactly is oral hairy leukoplakia, or OHL for short? Well, it's a classic sign of immunosuppression, and it's caused by the reactivation of the Epstein-Barr virus. It shows up as these white, kind of ridged plaques on the sides of the tongue. But here's the most crucial clinical feature. It's asymptomatic. It doesn't hurt at all.
Now, this is where a really key clinical distinction comes into play. OHL is often confused with oral candidiasis, which you probably know as thrush. But here's the dead giveaway for how you tell them apart. OHL is painless, and you can't scrape it off. It's stuck there. Thrush, on the other hand, can be painful or cause a burning sensation, and it scrapes right off, usually leaving a raw, red surface underneath. Getting that right is so important. Okay, so now that we've busted the myth, let's quickly run through the other statements and confirm why they're true. This really helps build out the full clinical picture in our minds. So statement B says that pruritus, or severe itching, is a common complaint. Is that true? Absolutely. It's one of the most frequent and honestly distressing symptoms for patients with advanced AIDS. It can be caused by extremely dry skin, specific rashes, or sometimes for no clear reason at all. It can really impact a patient's quality of life. Now for statement C about Kaposi sarcoma. This one is also correct, and it highlights a really important nuance. While KS is the most common cancer you see in AIDS, it's actually rarely the direct cause of death. Patients are much more likely to succumb to other opportunistic infections. The sarcoma itself usually only becomes life-threatening if it spreads to major organs, like the lungs or the GI tract. And finally, let's look at statement D about eosinophilic folliculitis. The description given in the question, it's a perfect textbook definition of the histology. If you take a skin biopsy, you will see exactly that, an inflammatory mix of eosinophils and neutrophils all clustered around the hair follicles. That finding is what clinches the diagnosis for this super itchy rash. So let's zoom out for a second. This stuff isn't just about one clinical question. The patterns we see in HIV have these fascinating echoes across the entire animal kingdom and even in the history of science itself. And you know, this isn't just a human story. Cats get feline immunodeficiency virus, or FIV, which also causes oral infections. That just goes to show you that oral health is a universal marker of immunity. Primates carry SIV, HIV's cousin, but they often don't even get sick from it, which gives us incredible clues for therapies. And we use special humanized mice to safely study how HIV progresses. All of this animal research directly informs how we understand and treat the human virus. It's pretty amazing. And you have to realize our understanding today is built on decades of Nobel Prize-winning science. It really started back in 1975 with the discovery of reverse transcriptase. That's the engine that makes retroviruses like HIV actually work. Then, in 2008, the prize was awarded for discovering HIV itself. And in that same year, another prize for linking viruses to cancer, which is the exact science that helps us understand things like Kaposi sarcoma and even oral hairy leukoplakia. See, it's all connected. Okay, let's bring it all home and lock in the key takeaways from all of this. I absolutely love this mnemonic, and it is a perfect way to remember the key features. Just think of OHL as the lazy plaque, It's not there to cause trouble or pain, it's just this quiet, stubborn warning sign that the immune system is in distress.
So, quick recap. OHL is caused by EBV, it's painless, and it doesn't scrape off. It's a key marker of a weakened immune system. That intense itching, pruritus, is very common in advanced AIDS. Kaposi sarcoma isn't usually the direct killer. Eosinophilic folliculitis has that classic biopsy finding, and maybe most importantly, the cornerstone of treatment for all of these conditions is getting the patient on effective antiretroviral therapy to get that immune function back up.
So, we'll end here. From a painless white plaque on the tongue to an intensely itchy rash, the skin is constantly telling us the story of what's happening inside the immune system. We just have to know the language. So the real question is, what other stories are we missing, hiding there in plain sight?